Oh, so we can't see anyone, but we know you're out there. Thank you so much for coming to this Contagion Cultures webinar, September 8th, 2020. We're broadcasting from the traditional territory of the Anishinaabe and Haudenosaunee. Queen's University was inaugurated on these lands in 1841 by Queen Victoria. Thus, this institution of higher learning is also an imperial project. We're grateful to learn and to work here and need to remember this history and strive to right the wrongs against Indigenous people. These wrongs continue to this day, and we hope that this series, which aims to incorporate and further various ways of thinking about how to best live with all of the planet, is a step in this direction. Contagion Cultures is a Faculty of Arts and Science collaboration between the School of Public Policy Studies and Language, Literatures, and Cultures, with Queen's Library providing substantive support. The talks are live streamed Tuesdays at 4 p.m. Eastern Daylight Time, Eastern Standard Time, until at least the end of December 2020. So we hope that you can pre-register and join us every week. The talks will be freely available online and archived at the library. And we particularly hope that these original contributions by our scholars will be deployed in courses in the future. Queen's Contagion Cultures lectures help to make sense of this pandemic through the expertise and insights of arts and science faculty members. This public-facing series leverages the powerful tools of humanistic analysis to grapple with our turbulent times. Today, it's my pleasure to introduce Abdelkerim Ousman. Dr. Abdelkerim Ousman is an associate professor and head of the Department of Political Science and Economics at Royal Military College, where he teaches international relations and public administration. Dr. Ousman's main research areas are strategic geopolitical analysis and security issues in sub-Saharan Africa and the Middle East. He has done research for the OECD and the Austrian Defense on fragility and resilience in sub-Saharan Africa. And Dr. Ousman's contribution today is entitled COVID-19, Redefining Fragility and Resilience of Nation States, the cases of Italy, the United States, Ethiopia, Germany, and Cuba. So we're very much looking forward to his talk. And as you're listening to the talk, please, if you have questions, please submit them to the Q&A in the bottom of your screen. If you can't see that, then just hover on the bottom of your screen until that comes up for you. And then we'll take questions at the end. We predict the talk to be between 30 and 40 minutes, and we aim to end in less than an hour, and so we should have plenty of time for questions. As webinar attendees, you are invisible and muted for the moment. So thank you very much, Dr. Ousman. Kareem, thank you for being here today, and we're very much looking forward to your talk.
All right, so I can share my screen with you to start with. Thank you for the good presentation. Here we go. Okay. Well, I have chosen those five countries because they are very diverse. They have different subsumption of capital to society, and some of them are capitalist, other are socialist. Some are like the United States, where the level of capital subsumption to society is very high, with Germany, with German states that enjoy certain level of state autonomy vis-a-vis classes, etc. So the whole thing is about defining fragility and resilience in the time of COVID. So as people know, the concept of fragility is a combination of risk and coping capacity in terms of economic, environmental, political, security, and social dimension. And resilience describes the ability of state and institutions to absorb and recover from shocks, with possibility adapting and transforming their structure and means for living in the face of long-term change and uncertainty. In all, what I have found out during this little research for this presentation, high-income countries and liberal democracy are supposed to be most resilient. But with COVID-19 pandemic, one would expect that most fragile states, like mostly in Africa, Middle East, and probably Latin America, to be insufficiently prepared to face the spread of the disease. COVID revealed that countries' income levels, type of political regime are not good indicator of resilience or fragility in coping with the pandemic. So the cases of Italy, the United States, Ethiopia, Germany, and Cuba rather demonstrate that the resilience in pandemic is determined by 4 factors, which have nothing to do with income level or type of political regime. Those 4 factors are whether health is a public good, that's very important in dealing with pandemic. Also, whether the state is relatively autonomous from social classes to ensure the equitable provision of that public good. And finally, whether there is a relationship of confidence between citizens and state institutions. But also, in all, the degree of capital substitution of society is very important to start with, because we know the degree of capital substitution of society is very high in the United States. When what is the reason? The reason is, and how that could be explained, because the United States is unable for many years to have really a budget, a national budget. Second, it has problem also dealing with with natural disasters such as Katrina, etc., and unable during Obama administration to have a healthcare system, and recently, obviously, unable to have a good policy and measure to deal with the pandemic. And before talking about the United States, we know that since the Reagan administration, the US appears to having difficulty adjusting to greater diversity at home and probably multilateralism abroad. Conservative America is plagued by a nostalgia of an imagined mid-20th century golden age. Bureaucratic havoc and backpassing during the pandemic have shown how the system is dysfunctional, and the decentralized and fragmented system of government appear to be not very well suited to respond to national trials such as COVID-19. US federal government way to defer to the state proved to be inadequate to the pandemic and a recipe for the current disaster of chaos and disaster. Now I'm going to speak a bit about the US health system. In the United States, most health insurance plans and services could be considered private goods. A private good is something that a person has to themselves and it's not available to another individual. The United States has one of the worst health systems among developed economies. That is being proven in many ways. A very large share of the population lack health insurance. A large number of Americans carry medical debt, and they die more often from preventable causes. The weaknesses in this system, which already put the US behind the spear on many health outcomes, are now being exposed in the COVID-19 outbreak. And the biggest problem, the one most unique to the American system, is cost. Cost is a real problem in the American health system. But even before the crisis even began, the United States has fewer doctors, fewer hospital beds per capita than most of other developed countries. During the pandemic have brought some obvious lessons. It shows that the US does not stockpile sufficient personal protective equipment, one thing. Second, poor infection control protocols in many of US healthcare facilities, lack of interoperability to quickly and easily share information between institutions that deals with health issues, shaky supply chain of vital medication, lack of humane guidance for people dying alone from highly infectious diseases, and diagnosis testing capacity are incredibly poor. Then the list goes on and on. But with COVID-19 emerging structural, there are many emerging structural problems in the health system. As living with the pandemic continued, deeper and more critical structural challenges become to emerge. As millions of people began losing their jobs, stopped showing up at their physician office, and delayed seeking healthcare, clinics, particularly small ones, were distressed, and hospital system began to run out of money. Millions of people lost their primary sources of access to care. The US health system stopped working for anyone except for the middleman whose only function is supposed to be to facilitate care, and the middlemen are actually the insurance companies. So the healthcare obviously felt some people even more, namely the people it already felt miserably, and I mean Black people and people of color in particular. So older, sicker, and poorer people have been suffering the lion's share of illness and death, not just because they were most at risk to the effect of the virus, but also because of deep inequality and racial bias that made them most at risk to shortcomings in the healthcare system. So the COVID-19 pandemic was an exponential shock to much of the US and exposed deep vulnerability across the US fragmented healthcare system and level of income. We know that African Americans who suffer from racial and income inequality also suffered disproportionately from COVID-19 incidence and mortality. Predominantly, Black counties have COVID-19 infection rates that are nearly 3 times higher than that of predominantly white counties. According to CDC, while they make up to just 12.5% of the US population, Black people account for 23 of COVID-19 deaths and are 3.5 times more likely to die from the disease compared to white populations. African Americans are overrepresented in essential jobs in the health and transportation sectors, where social distancing is impossible. From an early age through death, often lack access to good health care and are more likely to be poor. Long-term systemic barrier linked to racism in housing, opportunity, and other realms have exacerbated these problems. Due to these barriers, African Americans are also more likely to have pre-existing health conditions such as asthma, diabetes, and cardiovascular diseases, which are all at risk, which are all risk factor for COVID-19. Apart from these structural problems, we have in the United States a problem of political leadership. And that appeared how? Initially, for the president, COVID-19 was a democratic new hoax. In March survey after survey suggested that Republican voters are much less likely than Democrats to consider the virus as a danger. Apart from these delusion, we have institutional decision not very helpful with pandemic. For instance, we can mention the scrapping of the NAC dedicated pandemic unit, that is National Security Council, and CDC decision to stick with a faulty viral test. And to this, you can add turf war among the White House cronies and President Trump's xenophobic attack on China, calling China virus, Confu virus, etc., instead of dealing actually with the problem. And to this, you can add actually a lack of confidence in government, which was caused by the two wars that America was involved in, the war in Iraq and the Afghan war. Already the confidence that the people have in the government is really low. But the pandemic ended up being deadlier and costlier than the American and Afghan wars combined. And we have actually, after all, we have a really difficult awakening to of American. So the country long accustomed thinking of itself as the best, most efficient, and most technically advanced society in the world is now proving to be as made, at least with pandemic. And the fact that the US has failed on COVID-19 and China has succeeded in controlling it is a dreadful damage to all liberal democracy or countries that are aspiring to be liberal democracies. So we moved to Ethiopia, totally different country of above 100 million people. Ethiopia recognized early on that COVID-19 is a national emergency. The government understood that success in combating COVID-19 would depend on the public health measures, to contain the virus's spread, but the country did not implement lockdown, but took other essential measures in January, well ahead of most developed countries. The government scaled up its response in mid-March, when the first COVID-19 case was reported in the country. So what it did, it has encouraged productions and other economic activities to continue with the purpose to ease the major pressures on vulnerable social group and the informal sector. It has introduced strict passenger screening protocol at Addis Ababa International Airport. It is East Africa's largest aviation hub. The Ministry of Health and local and regional government jointly conduct house-to-house screening of more than 11 million households, containing 40 million people in the capital and provinces. That is almost nearly half of the Ethiopian population were screened. Also, it conducted diagnosis testing in May, was 5,000 tests per day. And the Prime Minister Abiy Ahmed make regular public announcement regarding COVID-19, while the Health Minister provide daily briefings. The government also conducted concerted media campaign to reach all citizens, emphasizing importance of hygiene, social distancing, and wearing face masks. It also had strict regime of rigorous contact tracing, isolation, compulsory quarantine, and treatment. It converted public university dormitory to increase the capacity of quarantine center to over 5,000 beds, establish additional isolation center with 15,000 beds, and set up treatment center with 5,000 bed capacity. It also introduced a comprehensive life insurance coverage to protect frontline health workers, which I find it very interesting and very generous. The government also made budget reallocation and emergency prioritization to contain the pandemic. The government COVID-19 economic support package is based on the principle of shared costs and sacrifices. So the employers, confederation, labor unions, and the government agreed on a tripartite protocol to prevent layoff during the crisis. Government subsidies have enabled manufacturing exporters to benefit from zero-cost rail transport and lower export logistic costs. Manufacturing policy also have been put in place to produce personal protective equipment for domestic and overseas markets. The government encouraged voluntary activity to address the public health emergency, with the government acting as a coordinator. It relied on community mobilization and public awareness campaigns, also relied on public health infrastructure and their extensions that was built up during the last 2 decades. Basically, it was like the extension of the socialist government, the socialist government infrastructure that exists. They expand them in prevention of such a pandemic. So the coordination among public agency at different level of government was really great in this case. before moving to Cuban case, I think we have to stop little in talking about the Ethiopian case. Ethiopia is a very poor country. It has over 110 million people to manage, but nonetheless, it was able to control, and many people talk about its success in controlling disease with little means and a lot of people to care for. So let's move to Cuba then. In Cuba, the communist-run universal and free health care system has proved key in containing COVID-19. Cuba healthcare spending per capita is about $1,234, is one of the highest in the region. The country also has higher healthcare spending, like the higher healthcare spending also equate to more doctors, nurses, hospital beds available to the public to help tackle the spread of COVID-19. However, these numbers still remain much lower than developed countries, but among the underdeveloped country or developing country, Cuba is clearly the first, even higher than Ethiopia. Cuba has also strong, high-quality manufacturing capability, along with advanced medical R&D capabilities. Cuba's decade of isolation has also resulted in increased self-sufficiency to meet the healthcare need of its populations. As such, the island has established a world-renowned health system and pharmaceutical industry. However, the pandemic exacerbates shortages of essential goods such as medical supply and food, but this is largely due to US sanctions. The US blockade also poses a serious problem for Cuban biotechnology sector. It makes it hard to import components of the drugs and hinder their commercialization. Likewise, the embargo reduces Cuba's ability to carry out the mass testing necessary to introduce their drugs on the international market and generate the funds required to finance the Cuban health system. But despite that, Cuba, first of all, recognized COVID-19 as a national emergency. The Cuban authority reacted quickly to the Chinese information about SARS-CoV-2 at the start of the year. Therefore, in January, before even the pandemic was declared in the country, the Cuban authority has established a national intersectorial commission for COVID-19, updated their national action plan for epidemics, initiated surveillance at port, airport, and marines, gave COVID-19 response training for border and immigration officials, and drafted a prevention and control plan. Cuba specialists traveled to China to learn about the new coronavirus behavior, and Commission of the Government Scientific Council began to work on combating the coronavirus. That's as early as January. So throughout February, medical facilities were reorganized and staff were trained to control the spread of the virus domestically. In early March, a science and biotechnology group was created to develop COVID-19 treatment, tests, vaccines, diagnostic, and other innovation. From 10 March, inbound travelers were tested for COVID-19. All of this was before the virus was detected on the island. So when the virus was declared in the island, on March 11th, 3 Italian tourists were confirmed as the first case of COVID-19 in Cuba. And that's the reason to declare that the COVID-19 is already in the island. Cuban healthcare authorities stepped into actions, organizing neighborhood meetings, conducting door-to-door healthcare check, testing, contact tracing, and quarantine. This has been accompanied by education program and daily information updates. The population went under lockdown on 20 March, was required to abide by social distancing rule and wear face masks when leaving home on essential business. Business taxes and domestic debt were suspended by the government. Those hospitalized had 15% of their salary guaranteed, and low-income households qualified for social assistance and family assistance schemes with food, medicine, and other goods delivered to their home. Workshops nationwide began to produce masks, bolstered by a grassroots movement of home production, and community mutual aid group organized to assist the vulnerable and elderly with shopping for food as long queue become the norm. On March 24th, Cuba closed its border to all non-residents, a tough decision given the importance of tourism in the country. Anyone entering the country was required to spend a fortnight in supervised quarantine under a testing regime. Defense council in the provinces and municipalities were activated. In response to the pandemic, it is clear that capitalist governments have adopted emergency power, introduced as the last resort in society where neoliberalism has put down deep economic and ideological roots. For a decade, Cuba have been told that the only free market ensures efficiency, and in this case, we have the proof that free market is not a real recipe, is not a panacea to dealing with the pandemic. And what we see that is the government, despite its little means, were able not only to control the virus in the island, but also to provide help to foreign countries, including Italy and many other countries in Asia and Africa. So Cuba has controlled the COVID-19 with some success, and that is undeniable. But let's remind that Cuba, with a population of more than 11 million people, is keeping the spread of the COVID-19 in check, and the island has fought the pandemic with success. That is undeniable. Compulsory masks, strict quarantining of people in isolation facility, and fine or even prison sentences for violating health safety measure contributed to a limited spread of the disease. In addition, Cuba's geography allowed it to isolate itself by suspending air and sea traffic. The country also has managed to control the outbreak better than many countries in the region due to its well-staffed preventative healthcare system. So despite its poor infrastructure, lack of funds, and a decades-long US embargo, Cuba has the highest percentage of physicians in the world, with 8.4%, with 8.4 doctor by 1,000 people, according to the World Bank. And that is one of the factors of the success. Cuba has long focused on family medicine, community work and disease prevention, and a network of hundreds of polyclinics that cover the country alongside neighborhood-based family doctor and nurse offices. This community approach, that's very important, help to detect cases early as well as communicate safety measures with the population. And these are really the factor of success for Cuba. Let's move to another big country, and that is Germany. Germany has the fourth largest economy in the world and spent approximately 11% of its gross domestic product on healthcare, with $5,119 spent per capita in terms of health. Germany also has the most hospital bed for 1,000 people, so 8.3, and a robust sector of private and public laboratory, of which nearly 200 indicate capacity for SARS-CoV-19 testing. The country also ranked among the top 5 countries in the European Union for the number of nurses, 13.2, and physicians, 4.2 per 1,000 people, and that is considerable. Germany has traditionally held the most restriction-free and consumer-oriented healthcare system in Europe. Health insurance is mandatory for all citizens and permanent residents of Germany, with approximately 90% of the population covered through non-profit, non-governmental insurance fund, and around 10% of the population covered through private insurance. In a Commonwealth survey, Germany has the lowest wait time for both consultation with specialists and elective surgeries. The user-friendliness of the healthcare system and its ample human resources and physical infrastructure have led to exceptional and continuously improving health indicators. For example, life expectancy at birth grew from 75 years in 1990 to 81 years in 2018, and the maternal mortality ratio also decreased from 11 deaths per 100,000 live births in 1990 to 7 in 2017. So, to say the least, the country is well prepared for a pandemic like COVID-19. Germany, like Ethiopia, like Cuba, has recognized COVID-19 as a national emergency. The German government entered the pandemic with a detailed national pandemic plan, together with generic preparedness plan and other disease-specific plan and document. This detailed response plan enabled the government to activate quickly with no time wasted on dispute related to governance, accounting, or cost, like we have seen in the United States. So there is real national cohesion in around the pandemic. So because also Germany is highly federalized country, the responsibility for public health lies primarily with an intermediate and local public health authority in 16 federal states and approximately 400 counties. Each level of jurisdiction has adapted the national guideline and recommendation to local needs. National authorities facilitate nationwide exchange and negotiate standard and common procedure for all of Germany. And that did not exist in the United States. So if we approach now the Germany's COVID-19 measures, the first case in Germany was reported on January 27th in Bavaria. On February 1st, the government further clarified reporting obligation and mandated that all healthcare providers report suspected cases of COVID-19 within 24 hours to local public health authorities. On February 27th, with 26 confirmed cases, the government set up an inter-ministerial national crisis management group. As the next day, the government required all travelers entering the country from high-risk areas, such as, at the time, China or Italy, to provide information about possible previous exposure and contact details. Testing was available at no cost to the patient upon medical or epidemiological indication, and testing for epidemiological indication was also recently included for asymptomatic contact or screenings. So the government also issued a daily situation report for the national and international public health sector on January 23rd, although the first report were confidential due to the granularity of the situation. These measures and basically the German healthcare system, the good attitude, the social and political cohesion of many jurisdictions to around the question around the pandemic has allowed real success in Germany. For the most part, social distancing guidelines are being observed, apart from the recent demonstration of French people who are demonstrating against social distancing and wearing masks. Germany has also shown several elements of success across the 4 phases of preparedness and response framework, meaning prevention, detection, containment, and treatment. The country's incredibly strong enabling environment, when we say enabling environment, is simply the political consensus, social and political cohesion, and good attitude to our government directive. That includes a good local public and healthcare system, an expert scientific institution. These has largely contributed to this broad-based progress with the pandemic. Germany did not prevent the COVID-19 outbreak, but the prevention protocols that exist in place facilitate the country's response to the outbreak. So in terms of protocol, we have early establishment of testing capacities, high level of testing, an effective containment strategy among older people, and efficient use of the country's ample hospital capacities. Local health authorities, the Robert Koch Institute, Germany Public Health Institute, and other scientific institutions have produced data and analysis to inform Germany's response. So the RKI Institute and scientists at other institutions were mobilized in early January to launch national crisis management to understand the epidemiology of the pandemic. So there are not only social good attitude, but also scientific endeavor to our dealing with the pandemic. Let's see in terms of detection. One of the first diagnostic tests for COVID-19 was developed at Berlin's Charité Hospital. The government worked to mobilize the country's public and private laboratory to scale up testing capacity. Later, Germany became a pioneer in polymerase chain reaction testing, which continued to feature prominently in the national strategy in dealing with the pandemic. In terms of containment, Germany's greatest success in this area has been relatively limited transmission in long-term care facility. Because older people are more likely than younger people to die from the virus, the country is at high risk because of its older population. The comparable low rate of infection among Germany's population over age 70 is probably one driver of its relatively low cases fatality rate overall. With a large number of hospital beds and careful planning, Germany's intensive care unit have not been overly stressed, although healthcare workers have had to contend with shortages of personal protective equipment. So overall, it is a real success. It is one among the successful countries, and I should remind that the success was due to early preparedness, good infrastructure, and social and political cohesion around the pandemic. Now, let's move to Italy. In Italy, there is no denialism like in the United States. Italy has a public health system like Germany, and health is mostly a public good like in Germany. But the sources of Italian difficulty with COVID-19 are the cuts that has been starting since 1990. Since 1990 is to deal with Maastricht criteria. Also, after that, we have the financial crisis of 2008. After that, we have the recent financial crisis, and all these were occasion for the country to be less capable, was occasion for more I would say, capital subsumption of society. Here it is through all those austerity measures during the last 30 years. To this, you can add Italy's tradition of Baroque legal drafting, legislative inflation, red tape, the neglect of previous assessment, as well as the lack of coordination across multiple decision makers and level of government. So when we talk about Italy healthcare system, it is a system that comprises a regionally organized national health system. The fundamental principle of the Italian national health system include universal coverage, social financing from tax general revenue, and non-discriminatory access to healthcare. The system is supposed to provide free healthcare at point of delivery and is regionally administered with the central government sharing responsibility with the respective region for healthcare services planning and delivery. The Italian health system was founded in 1978, based on the national constitution, Article 32. The state guarantees a universal right and largely free access to the healthcare service. So during the 90s, what happened? A first series of far-reaching reform was implemented in an attempt to contain costs in the face of the growing healthcare need for an aging population and rapidly improving technologies. These reforms were largely in line with the market liberal new public management approach, and their primary objective was to limit Italy's public deficit and debt. That allowed capital to subsume more of state power. Cost containment was therefore motivated by the macroeconomic context of the time, which was characterized by Italy's effort to meet the Maastricht criteria, let's talk about it earlier, and the requirement of the Stability and Growth Pact, which led to an overall tightening of public spending. Then more recently, the global crisis and the policy response of the euro crisis, it put further strain on the Italian economy and significant restriction on healthcare spending, returned to the national agenda. For several years, the Italian Observatory on Prevention has been providing in-depth analysis on organizational capacity, staffing, and competence across Italian region and territory. The observatory found many reasons for concern, which included systemic issues, such as impact of prolonged cuts and cost containment measures, widespread shortages of human resources, regional variation in the equality of services and outcome, aging workforce, like the average age of healthcare worker was 51 years, and delay in the digitization process, and inadequate budget allocation for preventive measure. So the country basically was disabled by those austerity measures to deal with COVID-19. On 30 January 2020, when the WHO declared the COVID-19 outbreak as a public health emergency of international concern, and on the same day, the Italian government banned air traffic to China. The following day, the Italian government declared a 6-month state of health emergency and entrusted the Civilian Protection Department the responsibility for the coordination of intervention necessary to deal with the pandemic on the national territory. On February 21st, the Ministry of Health ordered a mandatory supervised quarantine for 14 days for all individuals who had come into close contact with confirmed cases of disease. In addition, it required a mandatory communication to the Department Prevention in identified area from anyone who has entered Italy from area with a high risk of COVID-19, followed by quarantine and active surveillance. The Italian government impose increasingly stringent physical distancing measures, starting with the closure of 10 municipalities in Lodi province in Lombardy and one in Padua province in Veneto on February 23rd. In the same day, the Ministry of Health suspended all public events or facility of many nature open to the public in 5 regions in the north, meaning schools, gyms, public places, etc. Thereafter, additional social distancing measures were initially enforced in Lombardy and within area of other affected regions, and subsequently draconian lockdown measures were expanded and nationwide through several decrees enacted by the President of the Council of Ministers. First of all, schools on March 5th, banning of public events on March 9, limiting movement of people except if motivated by proven works need or situation of necessity on March 11, and then the suspension of all retailing and businesses activity with the exception of essential goods and production activities that were strategic or relevant for the management. So the national lockdown, with the exception of some retailing and businesses, was prolonged until May 3rd. But what we have, despite all the measures that have been put in place, and despite of policymakers' good intention, the measures they have put in place have often clashed with the country's complex legislative framework, including its tradition of baroque legal drafting, legislative inflation, red tape, the neglect of previous assessment, as well as the lack of coordination across multiple decision-making. Ordinary Italian legislation is verbose and unclear, often referred to as the dark law, the legislative trap, and normative metastasis. So basically, the lack of clarity, this style infused throughout the Italian legislation, only increase creative compliance and litigation by various levels of government. During the COVID-19 lockdown, an Italian prime minister decree included an obscure provision that people were only allowed to meet in person with relatives. Officials made the provision even more obscure by officially interpreting relative to include stable affections. At the same time, the lack of brevity increased both incomprehensibility and legislative inflation. All this is to say, people are confused, they don't know what to say, and plus, in the first days after Italy declared the state of emergency, the government published nearly 300 pages of rule, all interpreted by agencies, guidelines, and politician declaration. In addition, the president of the Italian region have regularly published numerous ordinances in response to the pandemic. These ordinances are not always consistent with national provision, and they risk government challenges in court. Red taping, authority have inconsistently enforced permit, lumping together both formal non-compliance with self-certification rule and substantive non-compliance with social distancing. The Italian approach to stay-at-home order involved extensive paperwork. This approach has added administrative burdens to regulating individual already complicated life. For 3 months, people in Italy leaving home to practice unauthorized activities such as walking their dog, shopping for food, or traveling to another region had to fill out a self-certification form, which changed many times throughout the crisis. So, like most Europeans, the Italian government has asked citizens to stay at home, but the compliance to this body, and that really has helped to spread the disease with many casualties. So in Italy, you have a good legal disposition for universal health care, but the cuts since for the last 30 years that affected the healthcare system did not help. Compared to Germany, they have almost the same legal system, the same legal provision, but not the same attitude, not the rational implementation of rules, and you have creative implementation procedure. I finish here.
Thank you very much, Kareem. That was a very meaty talk with lots of fabulous information. And we have quite a few questions relative to the amount of time that we have. And but in the meanwhile, let me ask a question that's come up around the question. It sounds like from your talk there's a benefit to a system that is leaning towards public healthcare as a public good rather than healthcare as a private good. And it seems that one of the criticisms of countries that care about healthcare as a public good is sometimes the question of how many rights people have. I was reminded recently of the UN's Declaration of Human Rights, and I was looking at the two distinct sets that they have and was reminded that one is civil rights and political liberties, and the other one is economic, cultural, and social rights. And it feels to me from this discussion that part of what you're saying is that in the time of a pandemic, what countries maybe that are often seen as robust because they seem to be robustly upholding the civil rights and political liberties of their citizens, like fail on the other side of these rights that are economic, cultural, and social rights, because they basically can't take care of the pandemic because their healthcare systems are based on profit. You were talking about subsumption under capital. I wonder if that was too long of a question, such that it's hard for you to actually respond to it, but I'm hoping that you will, because I'm sure you have a lot to say.
Okay, in terms of people's rights, most of these countries that I have tackled during this talk, they have, with the exception of the United States, they have universal healthcare system as much as they can. Even Ethiopia, with little means, with 110 million population, they have infrastructure for it. It is understood that as much as possible, healthcare will be provided for all. So it is somehow enshrined in their constitution. I imagine Cuba, you can talk to Cuba. It is also people's right. These are two developing countries, even though Cuba is not actually as developing as Ethiopia. And same thing for Italy, same thing for Germany. But the thing is, having the Italian case demonstrate that these rights, even if they are enshrined on the constitutions, there are other things that come to trump them. Like, for instance, the various cuts. The various cuts did not really care about people's rights. They simply, Italy have to comply with Maastricht criteria, dealing with multiple financial crisis, budgetary crisis, etc. Otherwise, maybe the country would be excluded from the European Union, etc. But that also entered the class struggle inside the Italian society, because all those you call them austerity measures become an opportunity for the capitalist class to basically dismantle state power in terms of healthcare. I mean in terms of education as well, in terms of provision of public good in various domains of activity, in various social domain and economic domain. So even when the right is proclaimed, depending on the political circumstances that the country is in. Italy, basically, these multiple crises through the year have become an opportunity to have more capital subsumption of society than, let's say, in Germany or in other countries. In the United States, it is clear. The country The level of capital subsumption in America is so high that the country is incapable of even having a budget. It is a national budget to deal with it, with the exception of the military, of course. The Obama administration, the Bush administration could not deal with Katrina. Obama could not have a budget or even the universal health care system that he wanted to put in place. Now, Trump, incapable of even managing what is going on. But that is not lack of capacity. The US is capable of dealing with things. But government after government, whether Democrat or Republican in place, they cannot deal with issues of public interest, with issues of public good, despite the fact that the country has a lot of capacity. I don't know if that answered your questions or. Yeah.
Thank you. That was fabulous. I'm going to take one more. Here, this one says, "What is new public management?" That's in quotes, in the Italian context.
In the Italian context, it's just the new liberal policies. People should be, government must have policies that are not costly to the public purse, responsibilizing people toward their own healthcare, multiplication of private healthcare facility, so those who can afford can, and basically dismantle, and the government institution, government money would not be dealt with as a public money, but as managerial efficiency that is closer to business rather than dealing with issue of public good.
Great, fabulous. Well, thank you so much, Will. I'm going to ask that we leave it at that. If people would like to follow up with questions for Professor Ousman, please email him directly. And I'll say thank you very much, Karim, for this really very meaty and interesting broad palette view of the way that different countries have been dealing with COVID, and whether it's in how far they've been successful based on certain criteria that include the amount, as you say, the capital subsumption of the government to capital, as well as the organizational structures that are in place that support or support less public good. I don't know if I'm fair at recapping that, so I'm going to give you the last word in case I massacred your rather complicated and insightful analysis.
Yeah, I mean, for me, what I retain from this, the the concept of resilience must be revisited. It should not just be income or political regime. It has to deal with the disposition of society to deal with public good. Public good must be central to the concept of resilience rather than other criteria that are ideological or political, because COVID-19 in those countries of different political regime have shown clearly regime doesn't matter, but public good, the notion of public good, that is very important for the concept of resilience. And the lack of it is clearly fragility. The lack of the notion of public good dealing with issue of social and social concern like health is the really basis for fragility. And I think my friends in the OECD must really revise their concept of resilience. Yeah.
Mm-hmm. Thank you very much. That's excellent. Okay, we hope to see you. We hope to see everyone again at the next sessions. And thank you very much. Take care and be safe.